We currently have one reversal agent that's very specific for one therapy. And so if you were on that drug, you would get that reversal agent. I think in the next several months we're going to have an additional reversal agent that can be a reversal agent to 3 of the other current therapies. So if you're on any one of those, you would get that reversal agent for that, but you wouldn't cross paths there. And so I think there's going to be some specificity for whatever you're taking. If you come to the emergency room and you need a reversal agent, tell them, hopefully know what drug you're on so you can get the right reversal agent, because they probably won't work, they won't work with the other agents. The reason is the mechanism. So for example, if you look at the drug called dabigatran, which is the drug that currently has a reversal agent, it's an antibody specific to dabigatran. So it will not work with the other agents. And if you look at we anticipate the approval of adexanet alpha, which is a reversal agent to what we call the 10A inhibitors. It will not work for dabigatran, but it would work for all the others. And so it's just the mechanism of action of how they designed the drugs. We'll start with the battlefield patient first. And in general, if we have a soldier that is on an anticoagulant, such as warfarin, for example, or any of these novel drugs, they're somebody we would not put in harm's way. And so we generally, that's a condition that would make them what we call non-deployable. And so we would not send them to an area where they're going to be, on the battlefield harmed and stuff like that, because that would obviously be putting excessive risk on their life, and so that's not a situation we hope to ever encounter. If someone's at home and they have a bleeding event, then if it's a serious bleeding event, I mean, this isn't just a minor skin prick or something like that. Now obviously taking these agents, if you scrape your arm or something, you're going to bleed a little longer, but usually that's not a need to go to the emergency room. But if you have serious bleeding, then the recommendation is go straight to the emergency room. Yeah, I mean, obviously put pressure on that, go straight to the emergency room. Don't treat this at home. The reversal agents, will be available in the emergency room. And the treatment for it would be best done in the emergency room, where they can assess your blood values, your blood counts, your kidney function, and treat you in accordance with the standard of care. I can tell you as a provider, there was way too much under-treatment in the Coumadin days. And you can come up with a million reasons for that. Warfarin was the #1 medication-related cause for emergency room visits, and the #1 medication-related cause for admission to the hospital. But at the same time, it was very effective. And so what we needed were options for people who didn't do well on warfarin. The example I use is that about 40% of the variability that we see in warfarin is due to genetics. So there were many patients that, despite our best efforts to control their INR values, their level of blood thinness, if you will, they were genetically not doing well on warfarin. And so being able to take that patient who was all over the map, they would come in and say, I've cut out all the green vegetables in my diet. I'm doing everything you say, but yet I'm all over the map with my INR. Being able to give them a different option, to me, is exceedingly gratifying. And that's a patient that many times ended up going on to nothing, or aspirin, which is inferior to a blood thinner. So I think a lot of those patients, that has given us tremendous options. It's obviously made life easier for our patients, where they can now eat their diet that they're used to. They can take most medications without worrying about significant medication interactions, although there are some very important medicine interactions with all of these new drugs, but the list is shorter. I think for me, the most compelling data is that when you take these novel blood thinners as a group, and you look at them compared to warfarin patients in the clinical trials, people on the newer drugs live longer. They have much lower mortality rates, and that's primarily driven by the fact that they have significantly lower rates of intracranial bleeding. And so it's much less likely to have bleeding into the brain itself, which carries a very high morbidity and a very high mortality level. And that's an interesting phenomenon, and I think it speaks to the fact that these drugs are very specific. They don't block 4 different pathways or 4 clotting factors. They work at a single pathway, and so we've seen a lot less bleeding in the brain with these, which is, I think, a huge benefit for the drugs. I don't know if there are new agents out there. I don't know if companies are developing new agents. I mean, I think now that we have 4 new agents plus warfarin, it's a pretty crowded field. The data is pretty, really compelling for these agents in general. I think this is the future. I think what we are still obviously struggling with as a society is making sure that we can afford the therapies, because they are more expensive on a per pill basis. Now, the cost that you recoup by taking these is because you don't have to do all the blood tests and monitoring, and you don't have to have the nurses involved for calling the patients and things like that. But yeah, so I think that is probably going to be the future, particularly when you combine them with a reversal agent that works very rapidly.